So the second part, you want to ask some question, please.
When a patient of diabetic retinopathy with a little moderate, severe or PDR case comes, I just I don't look at the eye for pallor. I look at his hand because he might be having instilled phenylephrine that will mask the cause more of pallor. Looking at the hand will help us a lot.
Not only hands, you should see the legs also. He has not dealt with the diabetic feet, but it's very, very frequent diabetic foot neuropathies, mainly peripheral neuropathies, which can cause diabetic feet manifestations. So we need to be more physicians. We should not forget what we have learned during our MBBS. That is very, very essential. Now I will go on to the diabetic retinopathy, the clinical features, because a lot of other diseases may mimic diabetic retinopathy, but we should understand what stage really these eye interventions, ophthalmic interventions. I will not now touch upon much about the systemic interventions, but eye interventions which may be required. So we should always understand that we are, whether retina specialist, medical retina specialist, or general ophthalmologist, we shall be able to deal with diabetes because it is an epidemic which is going on, and our country is in the highest prevalence of diabetic retinopathy, and almost all the diabetics, if you see, 35% are involved with some form of diabetic retinopathy. You cannot escape from managing diabetic retinopathy. That is one dictum I tell you. And you need to see there are three major stages which you need to identify, that is proliferative diabetic retinopathy, diabetic macular edema, and sight threatening, means both can contribute, and it is almost up to the tune of 11%. Now, though the early house classification is very, very old, it has given the posterior pole very much importance, and we need to see these 7 pictures. And the macular area, especially this grid, is very essential. If you see the rings, the central most is 300 microns, and then the solid line is 500 microns. After that, one disc area, the one disc diameter and 300 microns is very, very essential in your clinic to decide what treatment is applicable for these patients. So when you say, it is not the classification, actually it is the severity of diabetic retinopathy. It's from no diabetic retinopathy to very severe proliferative diabetic retinopathy. You should stage in your mind, this patient is reached this stage, so this requires this intervention. That is very, very essential. So you need to identify mild non-proliferative, moderate, severe, and I will come to very severe diabetic retinopathy as well, and the proliferative diabetic retinopathy. So whenever you are dealing with diabetic retinopathy, there are few signs you should always look for. And one classic sign is microaneurysm, which is the earliest sign. Though the vascular changes are described in the textbook as the earliest diabetic retinopathy signs, probably in the clinic you may not be able to identify. The number of intraretinal hemorrhages is again a very important aspect. The hard exudate formation shows that there is some kind of leaking activity which can happen with diabetic retinopathy. And cotton wool spots, though not given so much of importance, they indicate localized areas of capillary non-perfusion. So whenever you are seeing either color fundus photograph or an angiography or a red-free photograph, you should be able to look for which are the signs and what is the stage this patient is of diabetic retinopathy. So let us go back to our textbooks like ETDRS classification. If you see, they have given different stages of disease progression. Even the number of retinal hemorrhages, they have given a lot of importance. So very mild, you are seeing hardly any retinal hemorrhages there. And the second stage where moderate retinal hemorrhages, again the second picture is showing. When it comes to severe retinal hemorrhages, if in the clinic, even as a medical retina or a general ophthalmologist, you can count the number of retinal hemorrhages in a given quadrant. If it is crossing 20, anyone can count more than 20, you can easily count, and you say this is a severe retinal hemorrhages. And this is another sign which you should always look for, is venous bleeding. In this again, early venous bleeding is very very mild and it can be easily missed. You should identify that. So you can see the venous bleeding in the nasal side, especially in two quadrants. It's almost a different stage. And IRMA is another lesion which we need to be very, very well versed with, because these are again shows signs of severe form of non-proliferative diabetic retinopathy. And hard exudates, it can be part of non-proliferative, or there can be a simultaneous association between maculopathy and either non-proliferative or proliferative diabetic retinopathy. Maculopathy can be associated with both. So it can fit into any stage of diabetic retinopathy. And here you can see almost CSM is present there. So, why this is important, that severe non-proliferative diabetic retinopathy or very severe is need to be identified. So, we have given three points. One is intraretinal hemorrhages of severe nature. You need to identify the 20 retinal hemorrhages in one quadrant. That you need to remember. Any general ophthalmologist can also assess. Venous bleeding you should be able to identify, and if it is present in two quadrants, or moderate to severe IRMA, which I again shown you in at least one quadrant. If any one of them is present, it is severe non-proliferative diabetic retinopathy. Very simple staging. This, if two are there, then it is very severe. So it's important to stage non-proliferative diabetic retinopathy. It is in the clinic. Why it is important here? You see, in 1 year, if it is very severe non-proliferative diabetic retinopathy, half of the patients are going into proliferative diabetic retinopathy, and if you are missing these patients, then they can bleed and then severe complications can happen. So you need to pick the patients at this stage. Now let us temporarily go on to the diabetic maculopathy. It can again be a mild diabetic macular edema, moderate diabetic macular edema, or severe diabetic macular edema, depending upon how much the center of the macula is getting affected. And here again, you always see for exudates, but it is the retinal thickening which is very important sign, and which can be picked up only by slit lamp biomicroscopy with 90D examination. So you should be well versed with that examination. And ETDRS clearly defined the clinically significant macular edema, which means that this patient has risk of losing vision if you leave these patients untreated. Then in the clinic, you should not only concentrate on diabetic macular edema. There are other forms of diabetic maculopathy. Either it could be a cystoid macular edema or focal macular edema, ischemic maculopathy, or a combined diffuse and focal cystoid macular edema or ischemic maculopathy with cystoid or with traction. So you need to identify this, because the treatment or the management strategy differs with these patients. So this is an example of ischemic maculopathy. And OCT again you can utilize to the maximum extent to type 5 what diabetic macular you are dealing with. And if you see the staging, the international staging for diabetic retinopathy severity is different from ETDRS, in that if you see the severe non-proliferative diabetic retinopathy, it again identified as two different, one severe and second is very severe. Whereas in proliferative, again they stage differently in early, high risk and severe diabetic retinopathy. Can you identify any lesion here? At what stage it is? It's an early PDR, that is a neovascular, retinal neovascularization. This is a little bit more severe stage of proliferative. Again, still little bit more. So it is like high risk with complications. And this is like subhyaloid hemorrhage and very severe proliferative diabetic retinopathy, where the interventions can be very tough. So if you want to stage for a study purpose, again, you should follow this staging and the levels. With this, I would conclude that in the clinic, diabetic retinopathy should be staged so that your treatment regimen can be addressed towards that stage.